welcome to everybody. A warm welcome to everybody. It's my pleasure to open this webinar series. And the first webinar focuses on planning. And why are we doing this? As Tiago already mentioned, the webinars are very closely related to a special issue of health policy that we did very recently. You can find the links in the program, and Tiago will also provide the links in the chat. So we are doing this firstly because we are strongly believe that research evidence can improve planning. And secondly, we think that it is time now not only to highlight all the problems, they are immense, we know that, but we also believe we have some more opportunities, we have some capacities, and it is worth to exchange the knowledge and experience on what can be done. And that is the topic of this webinar. And we have a fantastic opportunity because we have an audience of 7 people and can bring together very many different perspectives. We start with our 4 panelists. Then we move on with 3 commentaries from leading organizations. And then I hand over to Tiago, who is moderating the chat. And that also means please use the chat. We are trying to make this as interactive as possible for such a large webinar. I'm very happy to introduce very, very briefly our panelists. We begin with Garrett Rees from the Lisbon University in Peru, who is also a consultant for WHO Europe and works since very long on health workforce research projects in Europe. Then we have Marjolein Dieleman from KIT, the Royal Institute in the Netherlands, Ivy Bourgeot from the University of Ottawa in Canada, and Niamh Humphreys from the Royal College of Surgeons in Ireland. And the 4 will share very short insights in their research. The floor is yours, Gareth, please.
Thank you, Ellen. Yeah, much of the work that I've been doing recently is really about looking at the effectiveness of health workforce planning rather than sort of planning itself. And so if we think about the work that's happening on health workforce planning, we still seem to be getting persistent or recurring problems occurring as shortages, maldistributions, perhaps underskilling in certain areas, and equities occurring. And so this got me thinking that perhaps the way that we approach health workforce planning is not as effective as we think that it is, and that perhaps we need to look at it in a deeper way at the problem itself and then examine the best type of solutions that we can put towards it. So this got me thinking that how do we do health workforce planning? So traditionally what we do is we get a model and then we think about projecting that model in terms of numbers into the future. And the problem with this is it locks in the past, the practices of the past and the institutions that we have of the past. But the health workforce problem is more long-term. It's about 15 years or so up to for specialist doctors. And then within this long time frame, we have different cycles like elections and policy competition coming up as well. We also have a large number of stakeholders, which makes it quite complex to do. But the good thing is the health is relatively stable. You know, things in health don't change quickly. And most countries do have some type of goal they want to achieve. They have a health strategy or policies that they want to put in place. So if we're thinking about this in terms of problem and solution, and in terms of health, in terms of future studies, this is what we call a normative future. And so we can examine a normative future, and then we can try to work out what we need and how we can get there and to be on track to get to that normative future rather than the one that we've been looking at traditionally with forward planning. And so if we look at this normative future, we can see there's 2 futures, one which is the desired or goal future that we want to achieve, and one that is this forward planning future. And between these, we tend to have a gap. This is the health workforce planning not necessarily working well. And so we can analyze this and we can use some techniques to get us back on track. Where do we want to be and how we can be there? And this is called backcasting. And so to do this, we look back from that desired future to the present, identifying what do we need to do, but also the barriers that get in the way for us to achieve that future. So we can plan to work to overcome these barriers with our stakeholders, put the right sequence of action in place, and try to get to that desired policy or strategy goals that we've put in place as well. So we're moving away from numbers into a more comprehensive type planning arrangement. So we plan for workforce governance and institutionalization within this methodology as well. And so this method isn't actually new. It's been around for a number of years, but it is sort of new for health workforce planning. And what we're seeing is some countries in Europe starting to adopt this type of planning. And it appears to be better meeting their needs in terms of planning for the futures, the structures that they need for the future health workforce, and more successfully identifying the skills that we'll need in the future as well. And so we think that this is an opportunity for countries to have a look at the way that they plan and start perhaps adopting new ways of planning to be able to overcome some of these persistent problems. So thanks for that, and back to you, Ellen.
Thank you very much. So over to you, Marjolein. Marjolein?
Hi, thank you. Sorry for this. Thank you for inviting us and reflecting on your question. You can hear me now, I think? Yes, oh, thank you. On the novel approaches and evidence for building capacity in shifting realities, it's important to also understand what shifting realities mean in practice, and that you also need to think of what do we have already and can we better use in a more effective way. So we have developed a framework to allow us mapping the evidence that we need and that takes the context explicitly into account. And we think it's important to not only plan the future supply, but also strengthen the current workforce, which means that planning is not only about numbers, but equally important is to retain health workers already at work and support their performance. Workforce in most countries are already very vulnerable, and this makes it that policymakers need to reflect on how to strengthen their resilience. And to do so, we think that we need a system plans approach to improve HRH planning. And this means strengthening capacity of decision makers to use evidence on different interrelated levels of the health workforce, like the individual level, the teams and organization level, and the national level, and the global level in terms of social, economic, and political context. And then we also need to think about, in practical terms, what it means at regional, national, and district level in countries. So decision makers for us, in being better able to plan, need to look specifically into understanding who our workforce is, that is their characteristic, but also their motivation, their drives, and where they live in, and how the societal context in which these health workers work and live strengthen or weakens their resilience, and this includes an intersectional lens. And in addition to quantitative data, we therefore need to collect lived experience of health workers and information community engagement and responses to support decision makers on developing contextualized approaches in planning. In addition, information on governance structures and the political economy of the health workforce system enables insight in the powers and interests of the wide numbers of stakeholders involved. That includes other ministries, decentralized levels of the Ministry of Health, private sectors, unions, etc. And using this knowledge on inter- and intrasectoral dynamics supports effective decision-making and identify feasible policies. So this means for us that effective planning requires a critical mass of capacitated HRH decision makers at all levels who have and use evidence that is timely and of good quality, which of course also requires staffing and institutional capacity for data management and evidence-informed decision making. So this will then allow us to strengthen governments to analyze their problems, insight in designing context-appropriate interventions, and to strengthen their stewardship to better address health workforce challenges in shifting realities. Thank you.
Thank you very much. Super. Over to you, Ivy.
Excellent. Thank you so much. I really appreciate the opportunity to speak to you today. So the work that we included in the special issue was very much inspired by what we describe as a quadruple I approach to planning. The first I being informed by the evidence, using high quality data to assess the requirements, capacity, and alignment of the workforce. The second I is interactive. We want to create tools that integrates both quantitative and qualitative data, qualitative intelligence from the local partners in our community. The third I being iterative, so that we want to embed into planning these cycles. Planning should not be ad hoc or one-off. It shouldn't be on a single profession. So the fourth I is that it's integrated and that it's interprofessional. And so the work that we did to create the foundation of a new, enhanced, and inclusive health workforce minimum data standard was inspired by work that we had been undertaking for now 9 years in the city of Toronto, an integrated primary care workforce planning approach. And what was informed by that process were a number of the data limitations. And we said, in the ideal possible world, if we could have these data elements, we'd be able to answer these questions, which are really important for the community. And so the actual planning process informed the data development that we undertook. We know that there are health workforce minimum data standards that exist, so we took a variety of them, we put them together, sifted and sorted, and then we took that to the community partners who want to be planning. And we didn't ask them, what are the data elements that you want? Because people don't think often in terms of data elements, but we asked them instead, what are the questions that you want to answer? And then we were able to work back from the top questions that they wanted to answer, top planning questions. What were the data elements that we need in order to answer those questions? And then we really kind of sorted that down to a very core and enhanced set of data elements. And then we worked with a number of partners to look at how that would get embedded into their data collection systems. And ongoing was some work from the WHO on health practitioner regulations, of which we had a part in. One of the key forms of guidance was to enhance registry data for workforce planning. Wasn't that we were going to have regulators do planning, but because they had that touch point every year with collecting data from registrants, that this would be an important place. And so just to round off, we've released this health workforce minimum data standard in the public domain. It is attached to the to our publication as a PDF, which is a PDF of an Excel file. And the work that we are doing now is to create a data collection platform for demonstration purposes that our different partners can adopt and adapt into their data collection purposes. And so we are really hopeful that with that, we will build a much more stronger foundation for better planning, embedding it in ongoing work and enhancing the capacity of those in the community to undertake that planning. So back to you, Ellen.
Thank you very much, Ivy. So Neith, over to you.
Thanks a million, Ellen. Thank you. So I'm delighted to present this research on behalf of the wider GP retention team. I'd like to thank Dr. Holly Hanlon, who led out on the research, and the HRB for funding it. So this paper is about changing work patterns in Irish general practice. So in general practice in Ireland, as in many countries, there's been a lot of change over the last few decades. GPs are now more likely to be working in multiple practices rather than single-handed practices, and there's a lot more women in the workforce than there were previously, 52% in the Irish context. And all the while these changes have been happening, the demand for GP services has been increasing and is set to continue to increase into the future. So what we wanted to know was how all of these changes have impacted on the work as done by GPs on the ground. So we undertook qualitative data collection with 20 GPs around Ireland using a method of remote ethnography. And that involved interviewing each GP online remotely twice and involving them in an 8-week back and forth conversation with the research team about their working conditions on a particular day or in a particular week. So it's a really good method if anybody's looking to use it for connecting with a busy workforce and a workforce that is geographically dispersed as well. So a quick plug for the method. But what we found in terms of how GPs were working is that they were using job crafting a lot to shape their working life. So they were using job crafting to reduce the work intensity of the work that they did and to improve their well-being and their work-life balance. The job crafting that they did involved taking on other paid roles in the health system alongside their patient-facing work. So they were maybe taking up roles such as a GP trainer or a GP leadership role alongside their regular GP work. And they felt that this increased variety in their workload increased their job satisfaction, reduced their risk of stress, of work-related stress, reduced their risk of burnout. And several mentioned that it increased their likelihood of being retained or remaining in the Irish health system as a GP in the longer term, which is great. Our study showed overall the importance of connecting the kind of national level GP workforce planning with the everyday work as done by GPs. I suppose there's no real one size fits all when it comes to GPs. And I think we can't really presume that new entrant GPs, new entrants to the workforce, are going to have the same, are going to want the same thing from their working life or from their life as the retiring GPs did. So there's a difference between the new entrants and the retiring GPs, which needs to be taken into consideration in workforce planning. I think overall, we probably need better data. I think several of our contributors have said the same. And we need better routine data, better research data on how GPs work, how many hours they work, how many of these hours are patient facing, and what other roles they do in the health system, which is not really collated in routine data sets at the moment. And I think all of that data on the individual GPs needs to be brought into the health workforce planning, into the GP workforce planning, in planning a stronger GP workforce for the future for Ireland. Thank you.
Thank you very much. Thank you also to our speakers for being so perfectly in time. We was having done so much broad work. I'm not able, in the sake of time, to comment on that. I just want to highlight that our speakers showed that there are capacities on all the different levels of health workforce planning. So that means it's not just enough to look at the macro level, or as some of you also said, to look at numbers. We have many, many other opportunities, and it's important to have this broader picture and use every opportunity, every capacity that we have. So before we move on, I just want to highlight that we also have other papers in these special issues that we were not able to include all in this webinar. And I just want to highlight one, what I think is really important for health workforce planning, and that is on the migration from Turkish colleague Kanberk Ayan, who has highlighted that there is a gap between the intention to migrate, which is usually the data that is used in planning, and the actual action that people take. So having said that, I thank you very much, and we move on to our commentators. And I would like to introduce Sharada Das from the CPME, the Standing Committee of the European Doctors. Then Michelle Falkenbach from the European Observatory on Health Systems and Policies. And then we have Chris Cotter from the WHO Europe. And over to you with the same question, more or less, to you. So what evidence and novel approaches are available from your side, and what is your experience? Please, Sharada, the floor is yours.
Thank you so much to the chairs for inviting CPME to present here. It was very interesting contributions already. I took many notes. Just to explain that CPME represents national medical associations across Europe, and our mission is to bring the doctor's voice to European policymaking. And workforce remains our #1 priority, and workforce planning is a big part of that. And we've actually been commenting on how to improve health data for quite some time. On the one hand, there is this belief that data can always be improved. On the other hand, of course, we see, I think it was Joseph Figueras once said, well, the data is good enough to see that there's a problem. So I very much agree with that. However, it is when we're looking at data, and doctors usually are in a more privileged position than other professions there to have relatively good data. However, there are still some long-standing demands, for example, to factor in training needs, to factor in time spent with supervision. We heard a bit new roles. There's a lot of discussion always around task shifting, etc., as if that would then free up time completely, but often it's linked to supervisory tasks. But also, as was already said, of course, there are newer trends, less than full-time work, looking at full-time equivalents rather than headcount in any case, also factoring in career breaks. These are all elements which we also believe would go to make data more real. And another way is, of course, to involve national medical associations where they hold the register of doctors, they are the data holders, but also in other cases, we see that our members can add a dimension of a sort of reality check to data. We see that some data categories are misunderstood or misrepresented often. We see there are categories that such as generalist medical practitioner, which are often used to describe general practice workforce, but is actually not that. So this would really be an appeal to also go to national medical associations and get their feedback on this. But of course, we don't just want beautiful data for the sake of it. We want to do something with it. And one of our appeals there is to look and to discuss safe staffing levels. We see this really as something very important, not only when it comes to the workforce, but actually in the context of the European European Health Union legislation. We were calling for better system data. So to be able to embed health workforce planning in a functioning system. But starting with safe staffing levels, this is something where we feel having national discussions and will bring definite advantages. And we at CPME carried out a survey in the past year, and we will be presenting the results also in the community of practice of the Joint Action Heroes tomorrow. But we saw there that where there are safe staffing policies in place, they are often not enforced very well. So that is again something where we then have to link up to how do we use this data in a really effective way. We also see that there is a disconnect with workforce planning cycles, and that safe staffing, of course, cannot sort of fix the health workforce shortages. So that is an important point. And lastly, one of our next policy of sort of priorities will be retention. This was also mentioned, where we want to then see what are all of these factors contributing to retaining health workers. So I would leave it there for the moment. Thank you very much.
Thank you very much, Sarada. So over to you, Michelle, please.
Yes, thank you very much for this opportunity to reflect on these really important contributions. First and foremost, I'd like to take one central message from the work I've been doing on the health and care workforce as it relates to forecasting and planning. And it's that forecasting and planning are really only transformative when they become part of a system's DNA. And let's call that institutionalization. So across Europe and beyond, we really have no shortage of models, projections, tools, and technical capacity, as we've heard, although we can argue about the data, as we've also heard. But what has really become clear is that technical excellence, although it's really very crucial, as we know, is not solely enough. Basically, planning makes a difference when it is embedded in durable governance structures anchored in legal mandates, supported by sustainable funding, and also linked directly to education, regulation, and service delivery. And this is a really powerful shift because it moves workforce planning from a periodic technical exercise, something that Gareth was saying, to a core governance function. And governance is a word that many people shy away from, very unsexy in a way, but it's quite important. And the resilience paper that we've heard about complements this beautifully. It reminds us that the health workforce operates as a multi-level system. So we have, as was mentioned, individuals, teams, organizations, and national and international structures, and they're all interacting under pressure in what we are increasingly calling and describing in our papers as a polycrisis. And institutionalized planning is not simply about producing better forecasts. It's about strengthening the system's ability to absorb and adapt and transform itself under these strains that we're being thrown at. The minimum data standard case from Canada and the lack of such data, as was mentioned in the Irish case, that also adds another crucial layer. So without interoperable, inclusive, and co-developed data infrastructures and even well-mandated institutions, we have no idea where we need to go. Data is not a technical afterthought, as is perhaps not surprising. It's a governance tool that we can use. And the collaborative process described in Ivy's paper highlights something really essential. And that's that planning legitimacy depends on stakeholder engagement. And finally, I'd like to come to Gareth's paper, this normative futures paper, which I thought was really interesting because it challenges the dominance of linear forecasting. And it suggests that workforce planning should be more strategy driven rather than purely projection driven, which is what we're seeing a lot now. And if we start from this desired health system future, an equitable one, an integrated one, and digitally embedded one, a resilient one, and then we work backwards, so backcasting, as he said, planning becomes aligned with a purpose, and it's not just a trend extrapolation. So if this webinar series has one core ambition, and it does, it's aligning research evidence with policy and practice, then these papers collectively show that we already have a lot of knowledge. The challenge now is this elephant in the room, as Ellen likes to call it, the governance of it all, embedding this knowledge into systems that endure beyond the electoral cycles and beyond individual projects and crises. Thank you very much. Back over to you.
Thank you very much, Michelle. So, Chris, over to you. Chris?
Lost the mute button. Apologies. Fantastic speakers. It's really hard to follow that, but I'll take some sort of thoughts. I mean, without a shadow of doubt, everybody's talking about the fact that we live in a complex and we work in a complex environment, and the complexity. I mean, that the sheer definition of complexity is that you really can't see that all the components are interacting together, and you can't infer behaviors. And that very much is the case in workforce planning. And I find that in many organizations, we exacerbate that by actually failing to think about how the system's operating again. And in so many systems, workforce planning is isolated. And I think we need, and all the speakers have talked about the need to think about integrating workforce planning into policy and service delivery design. So it's about asking the right questions and understanding actually what those questions are. And governance is the thing that was picked up on there by Michelle. And I have to say, we did a bit of research a year and a half, 2 years ago, where we did some assessment of governance quality in member states across Europe and how that compared to health outcomes. And what we found really was that the lower the investment level in governance of the system and of the workforce planning system, the less positive the health outcomes were. The UHC indices were low, and didn't really matter which element of good governance we looked at. The shape of the graph was pretty much the same. And that's represented a strong association between the two. So invest in governance is one of the things that I think we need to think about. Collaboration and integration of planning is really, really important, therefore, but also to think about the human factor and to remember that we're after safety and quality, and therefore developing workforce practice amongst the existing workforce and utilizing their skills and their experience is actually much more preferable than producing more and more workers. And countries need to think about investing on retention on a much higher level and a much better scale than they currently are. Even those countries who think they have good retention policies need to think twice about it, because it's very expensive to keep training additional workers. I think one of the things that we need to think about as well, and I think it came from what Michelle said and what Sarada said, it came a bit from Gareth and Ivy, was actually we're thinking about what workforce capability is. We're not necessarily thinking about what individual workforce competence is. And when we're planning for the future, and we're looking as Gareth talks about in the paper, we're not looking at a planned future or an extrapolated future, as Michelle pointed out. We're looking at something that links to policy. What does the government want to deliver, and what does that look like? What's the capability of the workforce required to deliver that, not just in terms of the competencies and the makeup of that team, but also in terms of what they're going to have to work with? Because we're doing a bit of future gazing when we're planning for the future. So there's all sorts of things coming in technologically wise, but also we have to remember that the human is at the basis of that. So I would say, if I was to summarize the big conundrum, is it is complex. We know it's complex, but let's stop shooting ourselves in the foot. Let's be much more organic and integrated in the way we do stuff, collaborative and relevant when we're making decisions, and defining what it is we're trying to deliver, but don't restrict ourselves when we're making the decisions to only the data that exists for that small area. Because one of the things around complexity is it's a big system. And so you need to take into account some of the other system levers when you're talking about that area that you're planning for. So I could talk all day, Ellen. So I'm going to come quiet now. But it is an inherently fascinating area that we work in, and I think it's constantly evolving. So, and we need to evolve with it.
Thank you very much. So, if there is anything to summarize from my side, then I really would like to say thank you very much. And it confirms so much what Tiago and I were hoping when we were thinking and when we started the special issue and decided to do the webinars, we do have capacities. We have quite a lot of capacities. We have quite a lot of interesting concepts, knowledge and evidence. The key issue really is to bring it into practice, and that I'm hoping this webinar can contribute to, because bringing stakeholders together, exchanging knowledge is an important step. But I leave it with this and hand over to Tiago.
Thank you, Ellen. So my role now is to engage with our audience, and thank you for the fantastic presentations. My impression is that our audience is convinced about the arguments. All the presenters and the commentators were very focused and coherent. There is one specific, so I think the message in terms of integration, institutionalization, crossed all presentations, crossed all arguments. There is one specific question on Ireland regarding the crafting. So I would like to ask Neve if she could expand a bit more. And actually, Ivy already mentioned that eventually, I don't know, in case of Toronto or other regions of Canada, whether this idea, this concept is being now used. So this is one question, direct question to Neve, and by the way to Ivy and others, if you want to step in, please.
So the question is, what is job crafting, is it?
Yes.
So the job crafting is basically adjusting work to better suit you in its essence. So it's just kind of changing your job to get better satisfaction from your job and to make it less intense, to make it more sustainable in the longer term. So in relation to GPs, they often call it portfolio careers. So it's taking on other tasks in order to make your job work for you for better, work better for you in the short term and in the longer term. That's what job crafting is. And that's what we found the GPs were doing. And that's great in terms of in terms of an individual kind of response to work pressures. It's amazing. They're kind of using their skills in different ways, taking up new posts in order to contribute to the system in a different way. But from a workforce planning point of view, if more and more GPs are working less than full time in patient facing roles, it will have implications for how many GPs we need. So it's just trying to link the individual solutions with the system again, and making sure that the system takes into consideration these changes in the ways GPs are working, and make sure that that's factored into workforce planning.
Fantastic, thank you.
If I could build on that response, this is exactly the type of modifications that we wanted to make sure that the data that we had in our minimum data standard were capturing. So there's two ways to do that. In my response, I said this is something that could go into scenarios, into a multi-stage process to understand population needs, workforce capacity, and then what might be happening in terms of this job crafting, which is really a fascinating scenario to consider. The other way, in terms of in our health workforce minimum data standard, in the capacity module, we really wanted to get beyond just headcounts and to be able to capture all the nuances in the way that different health professionals were practicing, including GPs. Health professionals have a varying degree of flexibility in their work. We need to ensure that our data systems are capturing that flexibility and that we are able to project not just on what people are doing in terms of direct care. They might be doing some research, they might be doing some teaching, supervision, and other tasks. But for actual what we need, what the population needs for the workforce, we need to get at that direct care. And all of these other dimensions are really important to look at what are sustainability of careers. But the data need to reflect the complexities more accurately. And that's what we were really trying to do, particularly with that module.
Thank you, Ivy. Chris, would you like to add something?
Yeah, I think what Neve and Ivy have said is really, really important. But I'd probably take it a little step further and put a challenge out to policymakers and to governments as well. Because one of the things that we all exist around the health workforce, the health service for the health systems is to keep populations from becoming patients. And I think one of the things that we need to really think about is where we deliver care and what sort of care we're delivering. And when we look at the demographics, it's not just an aging population, but there are all sorts of disease, NCDs, etc., that are growing proliferation across the world. And there has to be a thought that says, what do we do in terms of health promotion, prevention, management that takes care upstream and thinks about doing that work to keep people out of primary health care, keep them out of hospital, and get them out of hospital quickly, and transferring the load. Healthy populations have a habit of taking less health care, and that actually will reduce the pressure on the workforce. So it's not just, I think, about numbers. It's about what we do and where we do it as well. And I think governments have got some firm decisions to make that maybe in their local populations be unpopular at first, but over time lead to potential benefits for the health system.
Yeah, thank you, Chris. The message is clear. It's not only about numbers, it's about governance. There are two important topics in the chat that I would like to address you. One regards, obviously, AI and the use of these new technologies in planning. We are not talking about forecasting. We are addressing planning in this multi-level approach, including task shifting, task sharing, satisfaction, retention, and so on. So this is one topic. And the other topic, very important right now, regards how to plan in contexts of crisis and conflicts. So if anyone from our participants who could address one of these points or both.
Tiago?
Again? Yeah.
Just a brief comment on the last, and I think Marilyn might be able to put into this. We've done some work in this area. One of the challenges I think we really need to be alive to is conflicts and emergencies are are not going to go away. They're going to come around all the time. But the workforce that we have isn't going to swell to deal with the emergencies. So I think there's one challenge we need to build in all the time, is that we have that capability to step up and step down depending on the emergency or the potential conflict that's in place, knowing that actually our health systems are resilient enough and flexible enough to do that. I don't see that happening in many health systems. So we need to plan in this resilience, and we need to plan in this ability to deal with emergencies and conflict much better than we currently do.
Thank you, Chris.
If I may just comment on that as well, we are actually always a little bit astonished how little regard there is for workforce issues in all of the preparedness planning. When you look at the Union of Preparedness, it speaks very little about workforce. So that is really a gap, and something that we really hope at national level will go much better. When it comes to digitalization, of course, there is probably the discussion of using AI for workforce data to fill models. But also there, we would really appeal to use evidence on how this actually affects workforce time. If you look at administrative burnout rates, these figures are huge. So it would actually imply that in many cases, systems are adding work to the workforce rather than digital tools sort of freeing up time. So it's very important really to look at evidence, even at individual system level.
If I may add to that, can I?
Yeah, sure.
Also important to think about innovative ways. That's what I meant earlier in the presentation when I talked about community systems, and see how health workers work within the community, acknowledging also there's a lot of informal care happening, and that there's a double burden. As soon as crises come in, you have health workers who are also individuals and families, etc. So we really need to think about that and explore for innovative collaboration also beyond the health sector. I think there's not enough collaboration in multi-sectoral processes, and indeed in our work on the resilience of the workforce in crisis, we see that the multi-sectoral collaboration and the opportunities that are out there are insufficiently documented and explored. This is also for cross-border collaboration, civil service, military collaboration, etc. So there's a lot of work there to be done that I think would warrant attention and goes way beyond just workforce planning. And so there is, and I think we need to start doing that very urgently, because the conflicts are increasing as we see, but also the viruses, the other shocks that are going on are not going to go anywhere. So I leave it to that, but happy to hear what others think. Thank you.
Yeah, thank you. We have a couple of minutes. Is there anyone who would like to pose one more question? Ellen?
Can I make a short comment on that? Especially thanks everybody, but I want to add to this question or this comment on planning in high risk or under security, high risk security conditions. And with Thiago, Michel, and others, some are in this group. We have just published yesterday a paper in Health Policy where we looked at Europe and for Europe, or for most parts of Europe, not for all, or the European Union, the new situation that there are so many threats to health security. And we highlighted this issue that the health workforce must become a pillar, an important pillar of every plan, every budget, especially, that is related to health security. So I really think that is a key issue, especially also for Europe now, to include these issues in health workforce planning, and not only thinking of situations where everything is running smoothly. Thank you.
Thank you, Alan. One last question, because I think it's really important. About integrating planning with the topic of climate change and other environmental changes. Does anyone thought about this link? Ivy?
Yeah, I'll just add, this is something very important in Canada with many forest fires that we are trying to integrate into planning as a scenario. So just trying to understand what data can we capture and bring into those scenarios to build a more resilient workforce, because we are experiencing heat domes, we're experiencing like just rapidly and much more extensive forest fires. But also not just that you have the forest fires as the immediate concern, but the air quality. I mean, it has made international news, often because the forest fire smoke travels to the United States, and that has an impact on respiratory health and what are the capabilities of the workforce to respond to that. So this is an absolutely critical part to integrate into planning.
If I could just, if I could just add to this, the normative future is the way that governments have been addressing climate change through environmental policy, climate change policy, healthy city policy, reducing carbon emissions policy, because it's long-term in its nature and it's setting a goal. So when we're setting a goal for reduced CO2, the plan works in the way, what do we need to do to be able to achieve that goal? And this is similar to the idea that we're talking about here, is what is the goal of the health system? And you can bring in some of these other features, as Ivy just mentioned, into that desired future or that policy goal or the strategy goal, and then use some of these other techniques rather than just forward planning to incorporate some of these emerging issues that are becoming more and more important to long-term health needs, particularly around how these events will affect people, and we need to incorporate them in the planning. And the only way to do that is to really to have a long-term view rather than the short-term reactionary cyclic view that we have of planning at the moment.
If I just may add to that, because I think it's
last comment, please,
very
because you need to move to the
sorry, can I?
The session. Yes.
I just wanted to add that I think it's important to not forget the political dimension, because yes, all these future plans are very important, but don't forget the political cycles only run very shortly. What you very clearly see that COVID is very quickly forgotten. We have just got a new government in the Netherlands, and they really reduced a lot of already the healthcare, and all the vulnerable people have much more problems in accessing care because of reduction in costs, it moving towards now defense. So I really think it's important to think about how do we all talk about governments, it's much more than legal structures, it's really understanding the power and the interests of who has a say at the table and who participates, who has influence, and how do we navigate and look for opportunities of collaboration and engagement to get this back onto the agenda and make sure that the politicians acknowledge beyond their mandates sufficient resources and to allow this capacity of this planning to take place, because I think that's a crucial issue. And this whole political economy is it's everywhere being talked about, but it's very rarely really being put into practice, I've seen so far, in a health workforce planning. Thank you.
Thank you so much. I'm really apology for closing this moment, but we are approaching the end of the session. I would like to give the word to Ellen. So please, Ellen.
Thank you very much. So we have a very final round, and this time only to our commentators. I'm sorry for that, but in the sake of time. And a final question in 1 minute. What way forward to join forces and use capacities effectively for future health care and workforce planning? So shall we go on in the same direction? Sharada, Michelle, and then Chris. Sharada?
Thank you so much. So we've heard of the complexity. We are really calling for an EU-level strategy on the workforce that recognizes this complexity, that spans from health, employment, budget, preparedness, all of the factors that we've mentioned today, and sets out a clear policy vision so everyone is working intentionally and purposefully in the right and the same direction. Thank you.
Thank you. Michelle?
Yes, thank you. The way forward for effective health and care workforce planning in Europe join forces around institutionalization and capacity building. As mentioned before, workforce planning needs to move beyond this ad hoc exercise and become institutionalized within durable governance structures supported by the legal mandates, regular forecasting cycles, and sustained funding. And then countries have to strengthen their capacity for workforce intelligence and invest in interoperable data systems, analytical tools, skilled planners that are able to translate this evidence into actionable policies. And ultimately, I think we don't need to start from scratch. That's the biggest message I want to convey. There's so many things out there that are already working, and we need to identify those and scale those up. And one plug, there is a huge staffing report that is coming out to the topic that Sarada mentioned in the first round, and that is was written by the Observatory and in support with the DJ Santé and their health systems performance assessment expert group. So be on the lookout for that if you're interested. Thank you.
Thank you, Chris.
Thank you. Yeah. So I'm just as I work across a whole of Europe, not just the EU. One of the things I do find as a weakness is investment generally, but I would go further to say that in particular areas it's worse than in others. And if we go to the 2006 World Health Report, we talk about the health workforce as anybody who works in the delivery of healthcare, be they a porter, a cleaner, a doctor, a nurse, a government official. We've talked a lot about governance. Countries need to invest in the infrastructure that allows them to make wise and sensible decisions about the workforce, about how we train the workforce, about how we employ the workforce, and about how we appropriately develop the capability that our health systems need. That requires investment across the system, including those people who are making the decisions, not just relying on doctors and nurses in ever increasing numbers to plug the gaps. We need to have a much more rational, reasoned, integrated solution to workforce. And we need to think very clearly about where we're delivering about that care. That means health promotion, that means prevention, that means moving care upstream, and that means taking all the benefits from that.
Thank you very much. I think the whole session showed us really and confirmed how important health workforce planning is. It also showed us we do have capacities. We must just use them. And especially the last part, I think, showed us it's not only looking closely to the health workforce and to planning. There is so much more, and it is a key issue from my point of view for the future to use these, what I'm looking at, Michelle, the Observatory calls the co-benefits, looking at all these intersectional relationship and trying to find new sources, new budgets also to make it clear to policymakers without a health workforce, without proper planning, without a health system and service provision, all their other things will not work and they will not work properly. So that's for me the key message. I want to thank you. Before I hand over to Tiago, I want to thank especially Tiago and the team in Portugal, and of course all speakers and the participants. We have a fantastic audience. I think we have so many participants, which is really a big success. Thanks a lot, Tiago. Over to you. The final word is for you.
Thank you, Ellen. Basically, my closing remarks are to thank you all, participants, commentators, all the audience. We had an average of 124 persons attending. This is fantastic, and it's fantastic to see that the discussion could continue on and on. This means that all those who are interested have access to the link to the special issue, could contact the authors directly, or could contact us, and we will facilitate these contacts. I already put in the chat the link to our webinar series. Do not forget the next one on April 15th at 11 a.m. Central European Time. The topic, it will be about retention and sustainability, which everything is connected, right? So it's the next chapter, and please stay tuned. I also put the link to our collaborating center. All these initiatives will be available there. As you know, the recording will be made available as well. And please continue engaged with us, with this group of people that have been working together. And let's see other possibilities in the future. Thank you so much, and looking forward to see you in April. Bye.
Thank you very much, everybody.